morning, everyone in LinkedIn. I'm joined today by Claire Owen, who is part of the Bespoke Wellbeing team, and we are both occupational health and musculoskeletal physiotherapists. And we're going to talk today a bit more about the role of occupational health physiotherapy and how it can be used to support a return to work plan or process. So yeah, we've got a few points that we're going to discuss through. We actually created an event today, which is a new thing for us. So any feedback on that would be fantastic. And also, if you have any questions about what we're talking about, obviously not specific to any particular employees, of course, don't mention any names. But if you have any questions just generally about occupational health physiotherapy, do pop them in the comments and we'll try and answer them as we go along. I think I'm being interviewed today, aren't I, Colette?
Yes, you are.
Where should we start?
Yes, I'm turning the tables. So we've both been heavily involved in occupational health for many years, but it was interesting. I was on a working party recently about ARMA, so association research in arthritis, and a lot of it was around how can we improve the message to employers and employees regarding musculoskeletal disorders in the workplace. And one of the things which came up quite a few times was the return to work. And I suppose my first question to you is, what do we actually mean by return to work?
Yeah, so when we're looking at the return to work as sort of a term, we're talking about staff, employees who are off from work is the main one that we think about. And that can be sort of split into a few different categories. So it might be someone that is on long-term absence, and each kind of organisation may have a different threshold to what they classify as a long-term absence. But for example, you have a staff member who's been off from work for 4 weeks, could be your point where you go, actually, this has become longer term. So it's someone that's been off work for a longer duration. You then, of course, have sort of short-term absences, and these could be repetitive. So it could be maybe they've only been off a couple of days or a week, but actually that triggers something in your organisation about returning them to work. So someone goes off with a musculoskeletal injury, they've hurt their back. That will trigger them to alert the organisation that they've gone off sick with an injury and that they want to do something about it. And then the repetitive absence might be, if they've got an underlying injury or health condition, that they are having sort of short spells of repetitive absence. So they might have a day off here, and then 3 weeks later they have another couple of days off. A few weeks later they have off. Few weeks later they have a day off. So again, the triggers that organisations use, the tools that they use to trigger repetitive absence will vary, but it's that kind of repetitive nature. And that's actually although on a sickness absence policy there's procedures that might be taken, but also it is a sign that a staff member is maybe not coping very well in the workplace. So although they are coming back to work after a short period off, if they keep having repetitive absence, it is actually an indicator, isn't it, that something is going on, that is they're not managing, whether it is particularly work related and they're struggling to actually maintain an attendance at work. The other times that we think about return to work is when they've maybe failed a return to work. So someone, for example, could be off for 4 weeks, and then they decide their GP notes expired, or they've maybe seen someone or spoken to their manager and they've gone, actually, I want to come back to work now. I feel like I can come back. They come back to work, they last half a shift or a week or something, and then it doesn't work and they come off back into sickness absence, which, to be honest, is just terrible for everyone involved. It's really, really psychologically not great for an employee. They've been off and they go back, and then we call it a failed return to work, where they've just not managed. And that might be because there haven't been any adjustments put in place, that they actually did need something. They weren't back to normal yet in terms of injury level, and therefore they needed something. It wasn't put in place, or sometimes what is put in place maybe wasn't right. So whether they had like a staged return to work, a staggered return to work, but maybe it wasn't slow enough. And sometimes you just can't predict, sadly. Sometimes you think, actually, no, this is what we're going to do. We're going to make some adjustments, but actually it just doesn't work. Maybe they've come off some pain relief and actually that's just triggered things off. Or maybe they didn't stick to the guidance themselves of what you put in place. So it can vary. And the other type of return to work we talk about is when people, it links to long-term absence, but it's when people have been off a time and there just isn't a return to work plan at all. So this might be somebody who has a long-term health condition that's, become so aggravated that they can't foresee themselves going back to work, or maybe what they can manage functionally, like what they say their functional capacity is just so far from what their job requires of them that there's just no one can see actually how on earth we're going to get this person back to work. The other thing with that is if someone hasn't got a diagnosis or they're maybe waiting on interventions. So, for example, we've seen a few people, with some very sort of peculiar systemic things going on, and they present with back pain, for example, and sweats and all sorts. And actually, one lady I'm thinking of, we didn't know what was going on, so we couldn't predict the prognosis, we couldn't predict the timeframes, and therefore, how do we plan, a return to work in that person? Or if someone, we know what's going on, but actually they need a surgical intervention, how do we? There's not really a plan for return to work if nothing is changing with any other modalities and we're just waiting for surgical intervention. That return to work is you might not have a time frame for that either. So they're the sorts of things that when we're talking about return to work, we are essentially talking about getting someone back into the workplace and keeping them there, so maintaining them there, as safe to do so.
And it's often a stepped care process, isn't it? And there's often more than one person involved. So, from experience as a clinician, but also as a manager, there are often more than one person involved, which is a good thing, because I think the more people, but there's usually one person who's kind of leading that. But as you say, it's very much a stepped process, week 1, week 2, week 3. And I think, the more successful ones have been very much where that the member of staff has been really engaged and really involved in that. Because as you rightly say, if they have been off for a long period of time, their actual, for one, their general fitness will be less, particularly for, thinking about the type of the job they've got, but other things happen as well, so more the psychosocial aspects of things. So, and again, I think this does vary between companies, the actual length of time a return to work can actually be. What experience do you have of that, or what understanding do you have of that?
I mean, I'd say 4 weeks is the magic number, isn't it? So most companies will have in their policy or an agreement that for 4 weeks they'll support a return to work, and it comes down to what they will support, but also monetary. So will they pay for? Will pay up to 4 weeks. So what places will do, we'll say, we'll do a graduated return over 4 weeks, up to 100% of their salary, but then they can only do that once in a year. So, and I have seen people that have had 12, 16, 20-week phased returns to work, but they often will have a change in their salary for that short period. So, it depends on the employer and the organisation.
We also, from experience, have a number of situations where somebody's off work, they want to get back to work, we want to get back to work, but the employer will say they have to be 100% fit. We don't do a return to work, their job doesn't allow it, we don't have the staffing to allow that cover as well, which can obviously then be really tricky for everyone involved, because somebody doesn't have to be 100% to return to work. So how can we manage those situations, or what's helped when you've been dealing with companies? And
sometimes it's not always the companies, it's sometimes the patients, the clients as well. They're like, I'm not going back into that 100%, I'm going to damage myself. So the way that I normally broach that with, particularly with the patient, is we just talk about outcomes, and we know from the evidence and from our experience that people that get back to work quicker in a safe way, although they're not 100%, they do better. They get better quicker. and their overall long-term outcomes are better. And that's really powerful. It's like, if someone, a different scenario, but if someone has had a car accident, we always say to them, you try and keep moving, don't become rigid, try and relax, try and move as normal, get back to normal activities. And the people that do that, even though they're in so much pain and they don't want to move, you say the people that do that, they get the best outcomes and they get better a lot quicker. And I do the same thing with the workers, because if they're off from work, it has quite a negative domino effect of what they feel like, and I just go through the benefits of having them back. And so I do a similar thing with the employer. If they're kind of really tight on not having them back until they're 100%, you'll say to them, well, look, they'll be off for much longer. It's going to have a negative impact on their mental health. We know the stats about, the longer that people are off, the less chance there is that they'll come back, things like that. So I think talking through with them and just educating them about, what can be done. So, what are lighter duties isn't always a helpful term, but actually looking at, what are the amendments and adjustments. So it could be a graduated return to work, they could be supernumerary, it could be a temporary redeployment to another area if their particular work area doesn't allow lighter duties, and just educating around that. Sometimes you will still get some that, like, if they can't do 12-hour shift with all their moving and handling and repetitive bending, they're not coming back. So in which case then they're not fit to go back. Yeah. It's very, very difficult scenario. It's not always helpful for us.
Yeah. And so if we talk about the actual assessment, so if we were going to approach yourself and say, Claire, could you do a return to work plan for us? What do you need? What do you need to be able to fully assess somebody for a return to work plan?
As in, like, what would we do with the client, the patient? Yeah. So, I mean, the first part is the clinical kind of history. So talking to them, the subjective assessment. So this is actually really similar to an occupational health nurse or a doctor. So just finding out more about them, their story, their history, their injury. Was it an injury at work? Do they feel it's work related? Just getting a feel of what's been happening for them. All our normal physiotherapy questions. So around their pain levels, what aggravates them, what eases them, medications, just all the normal stuff, so that we fully understand what's going on. And some of those questions will start to help us have an idea of what is going on, sort of, as a diagnosis. So the subjective will tell us an awful lot. And then the bit that kind of differs from the occupational health nurses and doctors is then further on the diagnostic side of things. So actually doing a physical assessment. So having a look at whether it's online or face to face, having a look at observation. What can you see? Is there bruising? Is there any deformity? Looking at the range of movement, how they move, their pain responses, looking at the way they move functionally as well. So looking at them sit to stand, moving around, walking. We can get them to lift, look at their functional ability, and things like that. And they can also, we do our special testing, so our diagnostic testing. So if online, we get them to basically move, we'll show them the test positions and get pushing walls and doing different things to help us to see what provokes it, so that we can have an idea of what structures are inflamed or are injured. And so that gives us that sort of additional information, which is why we do take referrals from occupational health nurses and doctors as well, is because they want that diagnostic side of things to actually kind of go, okay, what is going on? Because that's super important, because that gives you the time frame for recovery and, importantly, the prognosis. And sometimes to be able to answer that question, when will they be back to work? When are they going to be fit to work? Are they going to have future absences? Is it likely that they'll be able to give us consistent attendance going forwards? And a lot of that decision making comes from that diagnostic evaluation. So they're the main things. And of course, I guess looking at work roles and the tasks and comparing that to the functional ability that we can see with them as we see them in person or online. So I think they're the main things. And then what was I going to say? Just looking at the work demands. I lost my train of thought. It's gone. It might come back to me.
Yeah, and I think it's really important to reiterate that even online as well as face to face, we can still do so much in that assessment, particularly the functional side of it. So I'm treating a car mechanic at the moment. I think he's a mechanic for bigger vehicles on a car. So it's very much show me the positions you're getting into, because that gives me a greater understanding of what he's actually doing at work. But also he can then say, this is what makes my back worse. And it's like, okay, right. Have you tried XYZ, or right, let's just, you know, tailor your exercises towards this. So
Mm.
it is, you know, amazing how much you can get them to show you, and that's so
Mm.
important, because, you know, there's so many, we can't possibly have knowledge of all the different job roles out there. And, you
Mm.
know, it really is listening to the, you know, the patient, and saying, right,
Mm.
tell me exactly what you're doing, and as you
Mm.
say about those job demands, how much time are you spending in this position? And it, you know, I think the chap was saying he's only in there for like, he's only in that particular position for 10 minutes, but he might be doing it up to 15, 20 times a day.
Mm.
Right, okay, well, let's, you know, look at that.
Mm.
So it's not always the heavy lifting which can cause a
No.
problem. It is
Mm.
those repetitive small movements people are doing as well.
Mm.
No,
I
it's good.
remember what I was going to say. Sorry, come back to me before I lose it again. I was going to say around the functional ability, and comparing what they can do and what their work demands are. Actually, prompted me then, is about the diagnostics. So, if, for example, you've assessed someone and you think they've got a cartilage tear in their knee, for example, and they get pain on squatting, knee flexion, getting some locking, you know that for a set amount of time, they're probably going to be exacerbated by deep squatting activities or like high steps, stairs, things like that. So it gives you that information to then report back to the organisation that actually we think this person needs to refrain from X duties for this amount of time, based on the pathology that you're suspecting, the diagnosis that you're suspecting. Yeah, came back to me.
Excellent. And so we've spoken about the assessment, and what kind of report would we be, or what kind of report could people expect to get from a Occ Health physio regarding return to work?
Yeah, we do two styles actually, don't we? We do kind of a short version and a long version. So our short versions are usually on, I think it's like 2 or 3 pages, but it basically gives an overview of the injury, sort of history, just a really brief history of what's going on. It will tell you where the injury is and what side it's on. It will tell you, I think is going through it now. It will tell you what their functional scores are. So we'll pick 2 or 3 activities and we try and make them work related, so that we score them out of 10, so the PSFS. So 0 is unable to do, 10 is able to do as normal. So we get them to score them, and then we reassess them at the end of treatment, so that we can see obviously changes, hopefully. And we also look at the objective assessments, so what we can find clinically, what we're suspecting is the diagnosis, the provisional diagnosis. And then there'll be a bit about work. So we'll say, you know, what their job role is. Are they at work or off work? And if they're at work, are they on modified are we recommending modified duties or modified hours? Any barriers to return to work, so we'll identify them and send them back to the employer or occupational health professional, whoever's referred them to us. And we'll also talk about any other recommendations in the workplace. So, for example, I don't know, if they haven't got a return to work plan in place, they're off sick from work, it might be that things that to start the kind of ball rolling in those conversations on how we think this person is going to get back to work, it might be starting to open up those ideas as well and what we think would be suitable. So I think they're the main things. So I missed anything glaringly obvious there? And how many sessions, I guess, as well. We say to them, actually, yeah, we think the prognosis is good. We need 4 online sessions, for example, and we'd give you an idea of how much, you know, is physio relevant to them, and is it going to help them get back to work? Yeah.
Cool.
And then
oh, sorry.
No, I was going to say, and then the bigger report, because that's a little one. The bigger report is sort of similar in terms of what you get back, but it is more written, it's longer. And in that's more if you send sort of full occupational health referral across. So if you've asked a specific occupational health questions, so that could be, of course, around fitness to work. It could be about giving consistent attendance forwards. You could be asking about any other risk assessments they need. More in-depth kind of return to work planning. If you actually want us to do that fully for you, then we can. So on a short report, it might say, so this person could consider a return to work in 4 weeks after starting treatment, physio treatment. We'd recommend a graded return to work with some adjustments to duties, avoiding deep squatting, for example. If it was a bigger report, then we would be saying, in 4 weeks, after treatment, we're anticipating a return to work, and we'd actually say week 1, week 2, week 3, week 4, and we'd outline to you what we would recommend in terms of which shifts to do, how long the shift should be, breaks between shifts, things like that. and any kind of conversations we think management might want to have with the employee, break down any barriers, or give you advice on that and things. So it's just a bit more in depth. If you've got someone, particularly if they've failed to return to work, you definitely want a full occupational health assessment. Or they've been on long-term absence, they've probably got some barriers that are starting to build around the return to work process.
And mentioned a little bit there about barriers and timescales and everything else. So what would somebody expect the kind of treatment an Occ Health physiotherapist would be offering?
Yeah, so personally, we're offering the online and face-to-face options. So online or face-to-face, you're looking at, of course, a robust rehab program. So we're using an app at the moment, which we're loving, where we can send out the exercises to people, and that's based on what they've told us, the diagnosis that we're working with, and to help. I don't really like the term work hardening, but getting them to return to work and looking at their work demands and what they need to be able to do. So we want to make the rehab exercise program as work focused as possible. So there's no point getting them to, I don't know, to lift like a dumbbell for biceps if actually they've got to sustain their arms over their heads switching something in for ages. So we want to make it as work specific as we can. We're big on advice and education and empowerment. So helping that person kind of understand, educate them what it is that's going to get them better, and giving them all that advice there, and that reassurance. We talked about loads on these lives, but the reassurance is so powerful. So giving them that encouragement and talking through their prognosis, their timeframes, helping them to understand that is really powerful. And then moving more into more face-to-face physiotherapy, you have the normal adjuncts. So things like manual therapy, puncture, taping, looking at any further physical testing we want to do, anything kind of a bit more hands-on, really, but encompassing all the other stuff as well. And then outside of standard kind of musculoskeletal physiotherapy, you then have things like workplace assessments. So it could be a DSD, ergonomic desk place assessment. It could be looking at someone's within the workplace. So we've seen quite a number of big vocational assessments where, like factory workers and distribution lines, where actually someone's been off work for a while and we're going in and we're having a look at them in the workplace at the tasks that they're potentially going to be going back and doing, or sometimes it's actually an alternative role that we're seeing if they would be suitable for, and that might be to recommend equipment, it might be to look at that return to work plan. So looking at how they tolerate things. So we might say, actually, yes, they can go on the production line, but they can only do like an hour in the morning, an hour in the afternoon. The rest of the time they need to be doing something else, which would help the employer look at. And sometimes it is a hand-holding process. People that have been off work for a while, they get anxious. I mean, I'm anxious just being home from COVID for so long. If I have to go and see someone in person, I'm freaked out. But yeah, like sometimes it is a hand-holding process. I've seen so many people that I've met in the foyer to then go into their workplace that are hyperventilating. Their breathing's changing. They're getting very anxious about seeing their colleagues and their manager and stepping foot back in the door. So just having someone external, impartial, coming in is really great, and it's a good. Sometimes people are so adamant they can't go back to work, and actually after the workplace visit, their mindset just switches completely, and they're like, okay, maybe I was blocking this a bit myself, and I was just super anxious, and actually I don't need to be, because my manager was lovely, everyone said hi to me, and I've actually had a go at some of the work tasks and they were okay, and I can see if I had that purchasing store I could manage, and they just have a bit more belief. So the workplace visits are, they're super powerful as well.
Yeah, no, definitely. And I think it's so key what you were saying there about that, the anxiety somebody might have, or the concerns that they might have after a time of return to work. Something which I'll often do with people is actually talk about their commute. So how do you normally get into work? Is that going to change?
Yeah.
Will the start finish times, if we change those, will that make it easier for you as well? So it's less busy on the train or whatever it may be, or sitting in traffic for ages. So even just going through the simple routine tasks of how are you getting to work and getting back, do you need to take lunch with you? Do you need to walk and get it? So all those little bits and pieces which might actually be playing on their mind, just because as you say, again, in the COVID situation, having not done that commute for a while, when you do have to do it, you are suddenly thinking, oh, okay, how long does it take me to get to the train station?
Yeah.
And often actually part of their rehab will be, right, take yourself to work. You're not going to the building, but I just want you to do that commute. Just see how it feels like.
Yeah.
What do we need to address? And that can be extremely powerful as
Mm.
well.
Exactly.
Good stuff. Any other take-home messages? If there were like 3 take-home messages.
Oh, I knew you were going to do that to me.
You always do it to me. That's why. What are your 3 take-home messages to perhaps somebody in HR or Occ Health who are thinking, right, I've got a member of staff here, we need to help get them to return to work. What's your 3 take-homes?
I think engage in help if you need it. So if you're maybe not clued up on it, or you've tried the things that you would normally use and it's not, you're unable to move forward, so you're getting stuck, I would just engage in help, whether that's your Occ Health provider or whether you go straight for an occupational health physiotherapist. It is engage in help, because the help is out there. I think a lot of people forget to use it, and the sort of stigma around occupational health and being sent to occupation not there anymore. There's been such good work on that recently, over the last sort of 5-10 years, that we are there to help. We're impartial, and it can just really help move the situation forward. So I think get engage in help where you need it. The second thing I always think about is just communication and transparency. So make sure that employee has a confidential space, an opportunity to talk to you. So if someone's having repetitive absence, for example, and you're feeling like, oh, we're having a bit of an issue here, just making sure that they have a return to work meeting, and that the manager, the line manager, is catching up with them, seeing how they're doing, and document people. Write down that you had those meetings and what was discussed and what the outcome was, but keep that communication line going. And a sort of, I guess, it's along from the communication side, but if you've got someone off from work, please do communicate with them, check in how they are. Many people we see, the barrier comes up because no one's contacted them, and just checking in to see how you're getting on, because they think that people don't care, and that people don't bombard people. Clearly, like, you don't need to bring them in. But just if they've been off for a while, just try and keep that communication line with them. Probably be my 3 top tips.
Yeah, I think that last one about keeping in touch is so important. I remember when I was managing big teams and you had somebody off sick, it'd be like, right, okay, let's agree a time which is good for both of us, where we can just phone up and just have a chat, see how you're getting on. Is there anything we need to do our end? And it was really positive. They kind of knew it was in the diary for both of us, that it was regular and always really helpful from both sides, actually. But it's so important. Just catching up on what was going on in the department and everything else is really
exactly.
important. Yeah,
exactly.
Lovely. Thank you so much, Claire, for your insight. No, it's really interesting, and so many factors, which I think would be really important for those people thinking about return to work. Thank you.
Yeah. Cool. Thanks for listening, everybody. And any questions, do post them below, and we'll come back later. Okay. Have a good day.
Thank you.